So this is a case involving hyponatremia and encephalopathy. Okay, so we have an 81-year-old female with extensive small cell lung cancer, and she has mets to the bone, brain, adrenals, kidneys, pancreas. She is status post palliative radiation and recent chemo. She has been admitted to the ICU for encephalopathy, possible UTI, and hyponatremia. Also of note, regarding her medical history, she had lung cancer diagnosed in December of 2021. And as mentioned, she had radiation chemo recently, and she had a recent hospitalization with urosepsis and had already begun palliative care prior to this admission. Now, the goal for the family and the patient is to treat the hyponatremia and encephalopathy in hopes of returning home on hospice. So here's the patient's outpatient medications. It includes macrobid, oxycodone, Eliquis, gabapentin, MS-Contin, fish oil, vitamin D3, dexamethasone, hydrochlorothiazide, omeprazole, Zofran, and doxylamine. And here are her inpatient hospital medications. These include Tylenol, Eliquis, ceftriaxone, dexamethasone, lidocaine patch, metoprolol, tartrate, ondansetron, oxycodone, and Miralax. So this slide is the patient's similar inpatient and outpatient medications. These include oxycodone, Eliquis, dexamethasone, and Zofran, all of which she takes in both scenarios or both settings. And the last line there, she takes MS-Contin, which is similar to oxycodone in that they are both opioid analgesics. So this slide includes medication interactions. Starting with the first line, MS-Contin increases the plasma concentration of gabapentin. Dexamethasone increases the concentration of Eliquis, which leads to increased risk of bleeding. We have Zofran, which reduces the pharmacological effects of acetaminophen. And the next two lines, oxycodone interacts with doxylamine, which increases the CNS depressant effects of oxy, so they get increased CNS depression from that. And oxy taken with gabapentin increases CNS depressant effects also of the oxycodone. And lastly, Eliquis taken with fish oil can increase the risk of bleeding due to the anticoagulant effects of Eliquis being increased. Here we have more medication interactions. When you take gabapentin with doxylamine, and it can increase the CNS effects of gabapentin. Hydrochlorothiazide taken with oxycodone has a couple of different interactions. It can increase the adverse effects of diuretics, which can lead to hypotension, and it can decrease the therapeutic effects of diuretics, so they may not work as well when taken with oxy. And when you take doxylamine with hydrochlorothiazide, it can increase the serum concentration of the hydrochlorothiazide, so you may get more effects from the diuretic than you wanted. And next we have vitamin D3 and hydrochlorothiazide. You can get increased hypercalcemia when those two are taken together. And lastly, we have acetaminophen taken with oxycodone. Oxy can actually decrease the absorption of acetaminophen. I don't know if this is a major concern, as we know Tylenol and oxycodone are given together frequently in the hospital. Okay, and this slide discusses outpatient medications that were discontinued while the patient was hospitalized. And the first line there, we had nitrofurantoin that was given for her previous UTI. That was discontinued and replaced with ceftriaxone IV. Because at this point the patient was considered to have a complicated UTI. She was already in the hospital, so it made sense to switch her over to a stronger, more effective antibiotic such as ceftriaxone. Next we have gabapentin. So this is another medication she was taking at home that was discontinued, and this is in the setting of her acute encephalopathy. So I believe we were trying to just minimize her somnolence, and so we gave her oxycodone instead, which she was also taking, but we gave her an increased dose, 5 to 10 milligrams Q4 PRN as opposed to just 5. And next we have MS-Contin, and this was also held in the setting of her encephalopathy. The patient was quite somnolent and minimally responsive, so it made sense to hold the MS-Contin to reduce that sedative effect. And next we have fish oil. As discussed earlier, it can increase the effects of Eliquis. Didn't want to put the patient at risk for bleeding, and it's just a supplement. These are often held in the hospital. Also, the patient is NPO, so I don't know of any IV formulations of fish oil that would be appropriate. The patient did not have a drop-off tube or an NG tube for enteral nutrition. Next, we have vitamin D3. Again, the patient is NPO. It's more of a supplement, not really detrimental to her acute condition. And next, we have hydrochlorothiazide, and we want to hold this medication because the patient is hyponatremic in the setting of SI-ADH, and further diuresing this patient may worsen her hyponatremia. Next, we have omeprazole. Again, the patient is NPO without enteral access, and so there's really no indication or access to give it at this point in her care. And lastly, we have doxylamine, which the patient takes at home as a sleep aid. And of course, we don't want to give this given her mental status, and she's already basically sleeping and somnolent. So we're definitely going to hold that one. So this slide contains inpatient medications that are not on the patient's home list. And starting on the left-hand side there, we have ceftriaxone. And this was initiated because it offers better coverage than the PO, nitrofurantoin. And ceftriaxone is more indicated for a complicated UTI, which she was considered to have now that she was in the hospital, and this was a persistent thing. And next we have the good old lidocaine patch. And she was given this as a safer alternative for pain control, because as we know, opioids will further exacerbate her mental status and possibly suppress her respiratory system. So like them or hate them, lidocaine patch, just another modality to help control her pain. And next we have metoprolol. This patient was quite hypertensive in the ICU, so they needed something to help bring her blood pressure down. And the risk with this drug is hypotension, bradycardia, and fatigue, although the benefits certainly outweigh the risk when we're trying to control her hypertension. And lastly, we have polyethylene glycol, or Miralax. This was a PRN medication, prophylactic for constipation, as the patient was taking several different opioids, which of course can lead to increased risk of constipation. And though it's not a concern with this patient, prolonged use of polyethylene glycol can lead to electrolyte imbalances, and we certainly don't want to mess with that given that she's hyponatremic. And now that we've discussed her medications and interactions, let's talk about how to do a great med rec. And point number 1 here says a good med rec form should be used. That this will allow the interviewer to ask the appropriate questions to gather information, because you're going to want to know how often a drug is taken, when it was last taken, and what dose the drug is. And having a good form will consistently help the interviewer get better information from the patient. Okay, and point number 2, it's great to have a reference of various medication types, and this can help the patients remember some of the less frequent, less common medications that they take maybe once a month, such as like a hormone, estrogen, topical formulations, because a lot of patients may not think of that as an actual medication, even though those can absorb systemically. And of course, herbal supplements. Many people or patients take these along with their other medications, and there can be interactions with those. And item number 3, it's great to have a list of standard questions that you can ask each patient, and this can help them articulate or specify the indication of these medications, whether they're taken it short term or for a chronic issue. And item number 4, this is important. It's great to have tools at your disposal, such as drug databases, tool identifier pills, and a list of local pharmacies with phone numbers, and also access to inpatient or in-house pharmacists. And I've found the pill identifier to be useful myself in helping patients with their medications. Maybe they don't recognize a certain formulation that the hospital carries that's basically the same medication, or maybe there's a pill that's dropped on the floor. We don't know which one it is. the tablet identifier is very helpful in those scenarios. Again, these are just some useful items to complete a good or great medication reconciliation. Moving right along, this slide discusses some clinical observations that I have seen in which MedRecs weren't done particularly well. First item here is an altered level of consciousness of the patient, whether they have dementia or an acute illness. I've seen pharmacists come in and attempt MedRecs on patients who aren't entirely there because it's difficult to know their baseline. So always make sure the patient is alert and oriented, or that the caretaker is familiar with the patient's medications. Polypharmacy is a big contributor to errors in MedRecs. For obvious reasons, we have different providers prescribing different medications, and these can be overwhelming for the patient trying to learn and keep track of all these medications. And sometimes the caretaker just may not be available to help with a MedRec, or the patient is unconscious and may not be able to participate. In which case, we just simply do the best we can with what we have by using medical records from outside hospitals or calling pharmacies, etc. And the next item is pretty obvious. We don't want to rush through MedRecs. We want to take our time and really make sure we get the most accurate med reconciliation we can get. And the next item, lack of privacy. I haven't thought about this too much, but it makes sense if the patient is on, say, an antipsychotic or something to help them lose weight, antidepressants, they may be a bit embarrassed by having to take that. And so it's important to give the patient privacy, have as few people in the room as possible so that they aren't withholding some of those medications. And the last point here kind of goes along with polypharmacy. Some patients simply can't remember all of their medications. They're taking 15 to 20 meds, and it's understandable why they wouldn't be able to recall medications, or maybe they missed some medications that they forgot they were taking. And so it's important to take our time and be thorough when doing these medication recs. So this slide has recommendations for orders and prescriptions for this particular patient. First, we want to avoid thiazides. We don't want to worsen the patient's hyponatremia. Next, we want to keep a close eye on the sodium levels, at least checking these Q8 so that we can intervene as necessary. Next, we have delirium precautions. Obviously, the patient is delirious and has some difficulty mentating, so we want to minimize distractions and help them to get a good night's sleep if at all possible. And next we have ceftriaxone for UTI. This is going to be a 5-day course. Next we have dexamethasone. We want to continue this to reduce inflammation and swelling related to her lung cancer and metastases. Next we have Eliquis. And just because the patient is essentially on palliative care, we still want to prevent arterial clots and thrombosis. And cancer is also a risk factor for developing these clots as well, so we'll keep the patient on Eliquis. And lastly, for her pain control, we'll continue oxycodone, and I would recommend adding dilaudid IV push for breakthrough pain. This is something we do in the ICU a lot, and these aren't large doses, but they're available PRN if the oxycodone just isn't controlling their pain very well. And this concludes my presentation. Thanks for watching.